I am joined today by Miss Pari Mohanna and Miss Maleeha Mughal. They are both consultant plastic and reconstructive surgeons at Guy's and St. Thomas Hospital in London in the UK. They specialize in breast cancer reconstruction, and we will be discussing one such autologous procedure today. Autologous meaning using your own tissue to reconstruct your breast. We will be discussing the PAP flap that stands for profunda artery perforator flap. For the viewers, we will be sharing slides today with intraoperative photos, so please be aware. If you are a resident, fellow, trainee, or a current surgeon specializing in microsurgery for breast reconstruction, this presentation and these photos will no doubt be of value to you. I will have information in the description of the video for you to reach out to either surgeon or the clinic that they work in. At the foundation, our aim is to provide access to care for breast reconstruction services around the globe. I am very fortunate to know both of these ladies and have met them at international medical conferences that I have attended. So for patients not interested in viewing surgical photos, providing contact information for Ms. Mohanna and Ms. Mughal in the description of the video will provide that access. Ladies, it is an honor to see you both together, and I want to thank you in particular for working so hard to make this happen. We are talking cross-continental, different time zones, all of the things. So I want to thank you both for joining me today on the educational channel. We have a good topic to talk about today.
Thank you very much for the invitation.
Absolutely.
Thank you, Terry.
Yeah, and it's good to see you again, Miss Mughal, because we have done a previous podcast on lymphedema, which I was really pleased to do. So let's talk about, before we begin slide sharing, let's talk about the work that each of you are doing over at Guy's and St. Thomas in London in the UK.
You go first, okay. Well, as you said, Terry, I'm a consultant plastic and reconstructive surgeon. We both work at Guy's and St. Thomas's, St. Thomas's being my base hospital. The remit of my work there is reconstructive surgery. My subspecialty is microsurgery, so I do a large volume of breast reconstructions there, microvascular breast reconstructions, autologous reconstructions, as you mentioned earlier. As well as that, I do abdominal wall and perineal reconstruction as well. And we're very fortunate. We have a great team there. I'm very lucky because I work very closely with Maleeha. And I think the symbiotic relationship is what's kind of makes coming to work so exciting. We love what we do and we love the company that we do it in, which then makes coming to work really enjoyable. And we're very fortunate to be able to provide the whole kind of repertoire of autologous breast reconstructions for our patients, either as an immediate or delayed situation.
Yes, and you know, I have to tell you, Ms. Mohanna, that I'm very happy that you mentioned your teamwork, because Ms. Mughal and I did talk about the value of that in the podcast that we did on lymphedema, that lots of studies have been done about the value of teamwork in microvascular surgery. So thank you for mentioning that. Okay, Ms. Mughal.
Thank you, Terry. So we've spoken before, but just as a little recap, I also specialize in macrovascular reconstruction, and my breast work is a lot with Miss Mohanna here. And then in addition to that, I also do head and neck cancer reconstruction and lymphedema, which we spoke about earlier. As a team, we provide a microvascular service to nearly all other specialties. And as Pari mentioned, that we do abdominal wall perineal. But in addition to that, we also provide reconstructive services to the gynae, cardiac, and pediatric surgeons as well.
Very extensive.
So we are very everything in-house.
Yeah. So let's focus in on our topic of discussion today, which is the PAP flap, and we will begin slide sharing. I will let you guys do that. And while we're pulling those up, I think that it's very important for you to tell the viewers, I gave the wording for what it stands for, the profunda artery perforator flap, but I'm going to let you share what area of the body that's taken from, why. You have an excellent slideshow, so I'm just going to leave it at that and let you pull it up and we will begin.
Whilst Maleeha's doing the tech side of things, just to put things into kind of perspective, the profunda artery perforator flap is to the TMG or tug flap what the DIEP or the DIEP flap is to the tram flap. So both of these are evolutionary procedures which started off with muscle being taken as part of the reconstruction. And then we've moved away from taking muscle. And in both cases, in the DIEP flap and the profunda artery perforator flap, as their acronym suggests, the word perforator suggests that it's a muscle preserving procedure. And the named vessel is taken with its perforator tributary whilst preserving the musculature.
Okay, I can see that very well. I can see both of you. Excellent introduction there. And so we can begin.
So just in a little summary, what we will try and cover this evening is a background of the procedure. Pari's already mentioned a little bit about that. What we have done in our series, how many patients we've had or how many flaps, and what our technique of operating is, what our results are, and a little conclusion in regards to how this type of reconstruction is for patients. So the profunda artery perforator flap, I think many of us would know, or those who don't, was described initially by Angry Gyani in 2001. So quite recently, if you look at the history of flaps itself. And then it was popularized by our good friend Bob Allen in 2012 for breast reconstruction. It's basically a flap, which Pari's mentioned, traditionally the old style tug flap, but the perforator is actually located posterior to it and involves more of the fat portion of the thigh rather than involving the muscle. So the muscle is completely spared because the perforators pass through the adductor magnus muscle, which is an adductor muscle. It helps you to bring your hip inwards. And instead of doing the long version, or in some cases you can do it with a linear scar, you can do it with a transverse orientation of the skin scar outside to mimic a closure which is similar to a thigh lift.
Okay.
I'll let Pari explain what our preoperative sort of setup is with regards to whenever we see a patient. In our practice, I think we do mention to patients, if you're examining them for donor sites with regards to autologous reconstruction, if they have both a donor site available for a DIEP and are also suitable for a PAP flap, then it could be that the patient makes a choice in regards to where would they like their donor scar to be. And then you can give them the pros and cons of the donor site scars and what would suit them better. Some patients who are active with regards to sports and Pilates and stomach exercises probably won't want to go for a DIEP, even though that's the gold standard, that's the flap that we all go for, and might choose to have a PAP flap reconstruction because the scar is more amenable to their circumstances or their choice.
Shared decision-making.
Exactly. So you have to empower your patient always.
Yeah, I love it.
If you have all the information, then they can make an informed decision. So with regards to examining the patient, of course, we look at all of the donor sites, making sure you've got enough pliability of the inner upper thigh. Once that decision has been made to carry out a PAP flap reconstruction, we do a preoperative CTA. This is very similar to having a CTA that you would do, a CTA meaning a scan looking at the blood vessels, similar to what we would do for a DIEP flap. And I know that for a DIEP flap, there have been many studies to show that doing the preoperative imaging or the preoperative radiological examination of the blood vessels can speed up your operative procedure. And it's all about efficiency in these cases. I think in my experience, and I don't know, Pari, if you agree, the preoperative CTA in a PAP flap is more for us to know that there is a perforator passing through the adductor magnus. I don't find that in our series it has increased or decreased in cases that we haven't been able to do a CTA because of the patient having contraindications to contrast or some other reason. It hasn't affected the total operative time or the operative time that it requires to raise this flap. But we do like to do it just so that we can see the perforator passing through the muscle. It kind of gives you a little bit of reassurance that it's there.
Sure.
I would say if you're a TMG tug surgeon and you want to transition to this flap, I would recommend getting the CTA for maybe your first 10 or so patients. If you decide then to drop that scan and just go according to Doppler findings just before the start of the case, that's fine. But I think when you're used to raising one type of particular flap, I think particularly in this circumstance, I think as a starting PAP surgeon, the CTA can be quite useful. And we'll just play this CT scan so you can see, because do you want to play? The CT scan acts as a roadmap for our operation. So it identifies the location of our blood vessel. So that's the gracilis muscle there that Maleeha is pointing out. And then behind it, we have the adductor magnus. And then you know where the blood vessels are because number one, they light up because the contrast that's been given, but also where they enter the muscle, there's a little cleft or rent, and that tells you where the blood vessel enters the muscle. And the reason we get this scan is because we want to see how far below the crease of the inner thigh these perforators are located so that we can then decide how to design our skin island in and around the position of these perforators. So essentially, these scans are the roadmap for the operation.
Mm.
So here we have a patient, and she's a very good representative of a patient that we would consider a PAP flap for. As you can see, our gold standard, the DIEP flap, is not really an option here. She's a very slim lady. She has no abdomen, and there could be a patient who's previously had either an abdominoplasty or the DIEP flap has already been utilized for a breast reconstruction. So for whatever reason or patient choice, the abdomen is rendered not a suitable option. And you can see in this patient, she's slim, but she does have some volume in her upper inner thighs, which I'll just point out with the mouse here. You can just see the markings that have been done here preoperatively. And whether you take the tissue from one thigh or two is dictated by, number one, the footprint of the breast. And when we talk about breast footprint, we're talking about the width of the breast and the height of the breast. And these two are fundamental in achieving an aesthetic reconstruction. The footprint of the breast is something that can't be compromised when one is carrying out a reconstruction. To a point, volume can be compromised if it's unavailable, because that can always be added to later on with fat transfer. But if the footprint of the breast, you don't get that right in the primary operation, it's something that's very difficult to correct downstream. So in this circumstance, when we talk about footprint and we talk about width and height, you can see that obviously in the thigh flap or the PAP flap, the markings go from a line which goes in the midpoint of the anterior thigh to a similar line. Let me just see if I have another. No, sorry, I thought there might be another image. To a line which is on the posterior aspect of the thigh, again, in the midpoint. And we go on the anterior aspect a little bit behind that. Here, this is just by the adductor longus. And the width of the breast is dictated by this point here, which goes all the way around to the back. So usually this flap is not a problem in terms of providing adequate width, because half of the thigh usually matches half of the breast width. The issue comes with the height of the breast. And as you can see, this height is not going to be emulated usually in one thigh. Therefore, you require two of these flaps. So when you stitch two elliptical structures together, they can form a semicircle, and that then forms the footprint of the breast.
So this then will be a unilateral.
So this could be a unilateral PAP flap reconstruction, but what we call a stacked PAP flap. So it means you've taken two flaps, one from each thigh. So sorry, we're in a room which is very sensitive to movement.
No
Maleeha's
problem.
moving her arms around.
No
I wish you
problem.
could see what she's doing now.
We can easily
Her
correct that.
Saturday Night Fever moves in the corner just to get the light. Apologies, everybody.
You know, if I might interrupt you a minute, I'm going to ask a question from a patient perspective. You brought up a really good point about this woman being slender and not, really having enough tummy tissue. But you also said that perhaps she had a DIEP before. So my question is, because I not frequently, I sometimes hear from women who have a flap failure and they go, I don't know what to do now. Well, so this is a perfect example. But I think sometimes in a patient's mind, they wonder, okay, if I've had a deep flap and I go to, say, a PAP flap, another type of reconstruction to replace the deep flap that failed, the arteries that are used within the breast tissue, then they can be used again for another autologous tissue?
That's a very good point that you raise, which we'll try and kind of approach in a systematic way, because it's a little bit more complicated, the answer to that question.
Okay.
So if you've had a failed flap, and particularly when you're changing surgeon, as much information that you can give as possible is very useful, because one of the questions is, why did the flap fail? And of course, this is a multifactorial discussion, and there's many reasons, but two of the most obvious is an issue with the initial flap raise, or an issue with the actual anastomosis. So we take these tissues from one part of the body, disconnect them from their blood supply and move them to the chest, and then we reestablish blood supply. So in this reestablishment of the blood supply, has there been a problem in that? Was it the recipient vessels because of radiotherapy that there were the problem? There's many, many reasons. But to cut a long story short, in answer to your question, just because you've had one failed flap, it doesn't mean you can't have another autologous reconstruction. You can, as long as there is tissue available, and also there are other recipient vessels available, which there are other recipient vessels available in that vicinity, which can then be utilized to do the secondary reconstruction. And sometimes you might have had a reconstruction and part of that flap has necrose, and then you have a quadrant that needs reconstructing. And again, you can use something like a PAP flap to do a quadrant reconstruction, and there again are recipient vessels available.
Thank you. If I had been sitting in consult and I asked you that question, that's the answer I would have wanted to hear and would have brought me peace of mind. So thank you.
So moving on from the preoperative markings, then is the positioning in theatre. With the traditional tug flap, we would put the patient on the table supine and then just what we call frog leg, bent and flexed at the hips and the knees and externally rotated. But with this, we find that putting the patient in a lithotomy position into stirrups is better, because then you can get more posterior onto the posterior aspect of the thigh where the perforators are actually coming out. And if you look at the markings on this, you can see that the anterior aspect of the flap stops just short of where the adductor longus is. And many of us can just, you can examine it on yourself as well, especially for the trainees who may be watching this or the residents, that the skin and fat overlying this area is quite thin. So there's not much volume overlying the adductor. So what we're trying to do is capture as much volume as we can posterior to all of this area. So we map the perforators like we did on the CT scan, and Doppler them as well preoperatively. The skin paddle is designed, and I think Pari touched on it a little bit when we were talking about the footprint of the breast. Now you can see that there are two crescents drawn here, with the superior extension of the flap being more sort of linear, and then the curving bit of the flap, the elliptical bit of the flap being the inferior boundary of it. We measure the whole height and width of the breast. We previously mentioned that the interior aspect of the flap is at the adductor longus, and you can take it as wide as you want posteriorly to match the width of your breast or the breast footprint. And then the height of it, if the height of the breast is 14 centimeters, that means you would require 7 centimeters on each side, because that would be 7 half circles. And then when we put them together at the end, they become the whole breast. Now, there are certain nuances to this part as well, because some people are quite keen, and I know that some of my colleagues here and abroad who do a lot of PAP flaps are quite keen to get a major part of the breast with just a unilateral flap. And it is possible, because you can chamfer or you can recruit more tissue going inferiorly down into the medial thigh, and by taking that with your flap. I find that a lot of patients will just ask that, can you just give me similar scars? Because I don't want to have the thigh lift appearance on one side and not on the other side. But it is kind of, if it's suitable for a unilateral, then yes, it's suitable for a unilateral, but I personally don't push the boundaries on getting a lot of tissue from the same thigh when I have the option of the other one. And once we have marked out all of our footprint and marked out the 2 semicircles, then in most cases, if we are together, we will park ourselves between the patient's legs, and one surgeon will raise a flap each. It's the same for our fellows as well. When they come over for training, they would each be parked between the legs to raise one flap each. And that's where we talked briefly about the co-surgeon model and how it's useful and efficient in reducing time that is required for slightly more sort of complex surgeries. We do use a sterile catheter. You can see there's a little green drape in the middle. There's a catheter hidden underneath it, and the catheter is then either left in the middle of the surgical field, dropping down and covered with a sterile drape, or we can sometimes flip it over the abdomen because that's out of the way, and then it's draped underneath that.
Just to reiterate, just a couple of things that Maleeha said. Again, just to highlight, so this is the adductor longus, and as you can see, the most anterior, the most medial part of this flap doesn't really cross that area, and Maleeha mentioned why, because the skin here is very thin, so no point going there, provides no volume, but also in this inguinal region, there's lots of lymph nodes, there's lymph node basin there. You don't want to inadvertently go into that area, because if you disturb the lymphatics in that region, you could end up with, excessive leg swelling in the form of lymphedema afterwards. So that's why we stay well away from that region. And then, as Maleeha said, you can go right onto the posterior thigh where the majority of the fat is in that region. And when these markings are being done, we like to mark it so that the perforator, which we've marked here, sits somewhere in the skin paddle. So if for whatever reason this perforator ends up being a little bit lower, we're of the mindset where we like to then shuffle this whole pattern of skin paddle further down the leg in order to capture this blood vessel, whereas some of our colleagues don't mind if it's on the edge of the flap. The reason we're laboring this point is that, of course, we want to place these scars. Once we close the thigh, ultimately, we want the final scar to end in the crease. But sometimes, if you move your flap down a little bit, it may not be in the crease, might be a bit lower than the crease. And even originally, if it starts in the crease, because of gravity and movement, there can be, like any cosmetic thigh lift, a bit of descent of this scar further down the thigh.
So the flap raise is done anterior to posterior. Previously, I think there was a little bit of a learning curve when many of us were more used to doing the tug flap. So we were keeping and protecting the perforators coming from the gracilis. We don't really do that anymore. We're more confident in knowing that there is, it hampers the progress. So we're kind of like, oh. So we go straight for the perforator that we know is coming through the adductor magnus. So it's suprafascial until we get to the gracilis, and then there is a little groove which you can identify anatomically, and you can just put your scissors through it, which lies between the gracilis and the adductor magnus. And once you've gone through that, then it becomes subfascial. And then you can retract the gracilis upwards and identify the perforator that is coming through the adductor magnus. The raise itself is very standard. Anyone who raises a flap would be able to just do it, and you get quite a good pedicle out of it. I think in our range we've managed to get from 8 to 10 centimeters, depending on how far sometimes you want to go, or sometimes as soon as you have a decent caliber artery and vein in your pedicle, we're quite happy to take that off at that point. But obviously keeping in mind that if you're stacking two flaps together, then you may want to keep some side branches available so you can join the two flaps together with your anastomosis. Both Pari and I are very, we're okay to do antegrade, retrograde, nearly maybe 95% of the time. It's rare that we will join the two flaps together. And yeah, I think with regards to the raise, that's pretty much, it's pretty straightforward.
Just a couple of points for the trainees out there. It's about having confidence in knowing your anatomy of this area. And because the adductor longus is a very cylindrical tendon, it's very easy to identify that both preoperatively in palpating it as an anatomical landmark, but even intraoperatively, once you feel that, the next muscle posterior to that is your gracilis. And of course, then the next muscle posterior to that is your adductor magnus. So you need to be confident in that, because you need to know that that's the gracilis. These perforators I'm seeing are the ones from the gracilis. So you need to go through those perforators and then reflect back. And then, as Maleeha said, there's a sulcus between the gracilis and the adductor magnus. And that's where you then need to enter and then split the fascia and then go into that region. And then when you go and incise the deeper fascia there and start reflecting it, those are the perforators, which are the profunda artery perforators. But we've all been there. We're in the first 5 or 6 cases. I'm like, Maleeha, is this the gracilis? Is this the adductor? She's like, yes, remember, this is this. So we've been there ourselves, but just, you just need to reiterate the long cylindrical tendon is adductor longus. Therefore, the one behind it is the gracilis. Burn through those vessels. The next muscle is the magnus, and those vessels coming through the magnus are the perforating vessels of the profunda artery vessels. So you just need to be confident. Obviously, with more cases, the confidence develops.
Yes, and again, I'm going to speak kind of from the patient voice. When you talk about the magnus, I think large. So if a patient, to give you a little hope that there are other areas of the body that have that fleshy, fatty substance that will allow you to build a breast, grab that inner thigh and go kind of behind there, because I guess I'm saying this because I was doing some exercises yesterday and I'm feeling those same areas that you were talking about, because I was massaging muscle that had kind of gotten overworked at the gym. And it is a lot fleshier kind of at the back of that thigh area, which is what you're talking about, which, you're talking about building a beautiful breast. So that's just a little patient side note there as you're speaking, and makes complete sense to me.
Now you've mentioned that, and that is, you don't quite capture all of that fat with the TUG TMG, because obviously those vessels are further forward or anterior, so that, we talk about angiosomes, areas of tissue which are supplied by blood vessels, and the fat right at the back is a little bit too far for those blood vessels to perfuse. And then if you try and attempt to take it, what happens, it just hardens and becomes fat necrosis. Whereas with the profunda artery perforator vessels, they do perfuse that area, which then allows us to capture this fat. And the difference between the fat and the muscle is that the muscle, once it's removed and moved from one location to the other and doesn't have any nerves going into it and doesn't activate like any muscle that we don't use, it atrophies. So whatever volume that muscle provides originally, with time that'll atrophy, whereas the fat that we transfer, as long as the patient maintains their body weight, that fat is there to stay.
Excellent.
So that's just an intraoperative photograph, and it shows on the left-hand side, you can see the perforator going into the flap here, and that's the length of it. We tend to use self-retractors because it's quite difficult to get someone to assist you with this procedure, keeping in mind that the legs are in a lithotomy position. You can't really have an assistant come across the table to help you with it. So a lot of the raise is done just as a single surgeon who can sufficiently just use instruments to act as assistants. And as we mentioned earlier, there is quite a long pedicle length that you can achieve with this flap.
So just to go back, just to again reiterate what we talk about, oh my God, sorry. When we talk about footprint of the breast, again, so here we have one flap, and you can see this flap is quite, you can see that that would easily be able to recreate the footprint in terms of the width of the breast.
Yes.
And then this would be the height of the breast. And in some patients, that is sufficient. If they have enough height available in the inner thigh and the breast is not very tall, then this one flap could be sufficient, especially if, as Maleeha said, you take a little bit more of an extension of the fat. That then adds extra height to the tissue. Even if you don't take the skin, you can take extra fat, and that can, what we call is chamfering, that can increase your height of the breast. But then if you imagine two of these stitched together, so this is the straight side, that's the curved side, so imagine another one of these placed here, and they sutured along that line, that straight line, then it forms, you can see a circle almost like an implant, and then it gives you double the height, but of course the width stays exactly the same.
Mm-hmm. That larger footprint we saw at the beginning.
Yeah.
Yes.
I'm going to let you explain
Okay,
these.
so
I love the photo on the right. That's both of you, correct?
Yes.
that's us.
The dynamic duo. I love that photo.
I mean, you can see that so this is what we call the lithotomy position for ladies who have had any kind of gynecological procedure or examination. That lithotomy position in which a gynecologist would examine you is the position that we place the patient in to raise these flaps. And as you can see, the spacing between the thighs is quite limited. But luckily, I mean, we're not too broad, either of us, so we can easily kind of sit next to each other and be able to raise the flaps at the same time. You may ask, well, why make it uncomfortable? Why don't you just do it one at a time? Surgery is all about efficiency, and we try where we can to be as efficient as possible whilst maintaining safety and quality and outcome. And we want to do the best operation, but we want to do it in the most efficient way to keep the patient's operative time to a minimum. So we raise the flaps at the same time for this purpose, so that the operative time is maintained to a bare minimum. But as I say, it may not be possible for, let's say, two kind of more body-built gentlemen to sit next to each other. They'd probably be elbowing each other. You know, we're just lucky that our frames match each other, and we can easily sit there and raise these flaps together. And we don't mind being in each other's personal space, and we both make sure we wear very nice perfume and deodorant first thing in the morning.
I have a quick question that came to mind. The lithotomy position, and I may be jumping ahead here, but I'm asking questions as I think of them too. The positioning, is there any, have you noticed any during recovery patients mentioning, any discomfort because they've been in that position for a few hours? Do you know what I'm asking?
Absolutely. So anytime we do any operation, particularly if it spans more than an hour and a half, one has to consider all the pressure points in a patient's body. So it doesn't matter if it's lithotomy, supine, which is lying on your back, prone, which is lying on your stomach. We do spend about 15, 20 minutes, sometimes even half an hour, getting the patient's positioning perfect, not just for the operation and for the ease of the surgeon, but also from a patient perspective in terms of protecting those pressure points, not having traction on nerves, etc. And the point you raised with respect to the lithotomy is an important one, in that these legs cannot be just maintained in this position for an indefinite period of time. So therefore, we do monitor on the clock what time the legs go up into this lithotomy position. And in general, the time it takes us to raise these flaps is within the acceptable time. You know, within an hour or so, an hour and a half, one should bring the legs back down, allow the circulation to normalize back into the lower leg and the calves and the toes, etc. And if you need to continue, then place the legs back up into the lithotomy position. The reason for this is if you drain the lower leg of blood for a significant period of time, and then you put the legs back down and the perfusion reestablishes itself, that kind of increased pressure in that compartment can cause something called compartment syndrome, where pressure is too high and then you need to do an operation to release that pressure. And therefore, we are very mindful of all of these factors and make sure that, number one, we try and be as slick as possible with the surgery, but sometimes, you know, things, the anatomy doesn't allow for that. Then we know we'll stop, bring the legs down, maybe even massage the legs, and then put them back on. And remember, the patients are wearing pneumatic compression stockings, which is almost like a blood pressure cuff when they take the blood pressure on an arm, but this spans the entire length of the lower leg from below the knee to the ankle, and that intermittently goes up and down, stimulating those calf muscles to push the blood back into the circulation. So there is that pneumatic compression stocking as well to kind of minimize the chances of getting kind of deep vein thrombosis.
Thank you. Perfect explanation.
So as we kind of touched on this a little bit earlier, once the anastomosis is done, antegrade, retrograde, if you are joining one flap to the other, then you would join the pedicle of one flap onto a side branch coming off the other. Because these flaps are coming from the inner thigh, you usually can find a decent enough side branch which has good caliber artery and vein in it that you can do an intraflap anastomosis. Otherwise, the antegrade and retrograde IM vessels, which are standard for stacked flaps, and everyone is kind of aware of those, then you can use them. We had the true crescents, and then we joined them together. So we suture them in the midline, and then place them in the pocket. So as the bottom diagram or the bottom photo shows, this is how the end sort of footprint of the breast is recreated. Now, this patient had a nipple-sparing mastectomy, hence all the skin off the flap has been taken off and removed because we are going to bury this, this flap underneath the actual native skin of the breast.
So for those who obviously are not medical background, so we talk about recipient vessels. Recipient vessels are the vessels that we use to reestablish the blood supply to our flaps. And in general, our choice of recipient vessel is what we call the internal mammary vessels, which some patients may have heard of, which are the vessels that traditionally used to be taken for cardiac bypass grafting. And these sit under the costal cartilage. So we make a little window in the costal cartilage, or sometimes you can go in between the costal cartilage and preserve the costal cartilage. And then you'll see these two pipes, the artery and the vein. There can be two veins. And then when we talk about antegrade, retrograde, antegrade is when it's in the direction of the flow of the vein. So it's kind of going upwards. So we generally put our flaps on an antegrade system. However, the way these vessels function, you can also use the other end of them, both to provide perfusion to your flap or to drain your flap. But if there's a circumstance where this is not suitable, then as Maleeha said, we keep big side branches. So we piggyback one flap onto another. So one flap will be on the antegrade system and the other flap will be like a piggy bank or a parasite on the first flap attached to a side branch, and it's getting its blood supply through the first flap into the second flap. So that's called stacking or piggybacking.
So donor sites are quite important when it comes to autologous reconstruction because it is a surgical site that you didn't actually need to begin with, and you've chosen to have it. So it's extremely important that you have minimal complications. And for us, it's definitely been a little bit of a learning experience and with regards to our donor sites for PAP flaps. It's a tricky area. It's somewhere where when you're sitting down or a patient is sitting down is where you have direct pressure. It's also high up on the inner thigh. So, you know, going to the toilet, it's an area that is never going to be 100% sort of out of the way of other things that you have to be involved with. And we struggled a little bit in getting this kind of right and sort of okay for a while. We don't put any drains in, similar to our DIEP flaps. We have a drainless closure, unless there's quite a lot of tissue that's been recruited from the thigh, and there is a bit of dead space on the upper inner thigh, which you want to suction down, then a drain is used. But a very few number of patients in our series have had that. I would say less than 3% would have had a drain in. And we use the Stratifix suture, which is a barbed suture. So it has these little ends to it. It's very similar to our old style PDS suture, but it has barbs in it. So it doesn't require a knot, or it doesn't require repeat knotting. We used to use just a running Stratifix suture throughout the length of the wound in 3 layers. And then we had to change it because we had early opening of these donor sites, then requiring resuture, either in theatre or requiring a vacuum-assisted closure dressing. So that led to us sort of changing practice, and we started doing separate interrupted sutures in 3 layers, and then just using the Stratifix barbed suture in the superficial layers. And then we have a sort of glue type tape, which is standard to all of our surgical sites in our hospital here.
So again, just talking about the donor site. So when we talk about the gold standard that we call the DIEP flap, we always discuss with the patient. So the tissue from this area, when we take it, the result on the abdomen is similar to a cosmetic tummy tuck procedure, where we do the tightening of the muscle and we do the contouring of the abdomen. And essentially the end result, when you look at it from the end of the bed, is as if the patient has had a tummy tuck, although of course the operation has been more involved and we've had to go through the muscles to get the vessels. With respect to the PAP flap, it's as if the patient has had an inner thigh lift. So that is kind of the 2 cosmetic parallels of the donor sites, the PAP versus the DIEP flap.
And with regards to flap monitoring, we use flow couplers for any flaps which are buried under the skin. And if we do have skin visible on the outside, in case where the nipple has not been spared, then we would use the traditional handheld Doppler that we are quite, which is regularly in use everywhere. With regards to the flow coupler, we also use it in patients who are dark-skinned, because having skin changes when there is venous congestion or a compromise to the venous sort of blood outflow, it's quite difficult for that to be picked up in a dark-skinned patient until things are way further down the line. And with flaps, if you are to salvage something or a situation, the sooner you can get it back to the operating room, the better it is in terms of salvage outcomes. So we use a flow coupler. I appreciate that this is not something that is utilized everywhere. A flow coupler is essentially a little Doppler monitor which is attached to the standard coupler, and that has an external box that you can listen to the flow from.
So just in terms of what do we mean by a coupler? So when we have 2 vessels to join together, as we know, in the body we have arteries which bring oxygenated blood to a location, and then we have veins which take the deoxygenated blood away. So the consistency or the architecture of these 2 vessels is quite different to each other, and the arteries are much thicker walled and stiffer, whereas the veins are much thinner walled and kind of compliant and stretchy. So in general, our arteries, when we join them together, we hand sew them. Obviously, we use a microscope or high magnification loops for this. So it's hand sewn with very fine suture, which is thinner than hair. With veins, traditionally we used to hand sew these, but because of the nature of the veins, etc., hand sewing veins is slightly more challenging. Not that we mind challenges, but a device has been created called the coupler, which, if you can imagine, is 2 donuts. So it's the shape of 2 donuts, 2 pieces of plastic donuts, and then Each of the donuts has metal prongs coming out of them. And what happens is, if you imagine the center of the donut, the vein is pulled through the center of the donut. And because it's nice and pliable, the edge of the vein is then brought over the tops of these pins. And then the pins pass through the vein, keeping it in this open position. So one vein on one side, one vein on the other. And then the applicator is closed. And when the applicator is closed, the donuts bringing the veins come together, and then the pins interdigitate to the other side where the plastic doesn't have pins. And then the whole mechanism is deployed. And what you have is a structure which has the two donuts pinned together, and then the vessels on either side. And this is what we use for our veins. And what Maleeha was saying is we have standard couplers, which are just the coupler, or we have the flow coupler, which is basically the coupler with a little side arm, which then has this wire which comes through the skin. You can see that here, which connects to a machine, and then we can hear the signal.
Mm-hmm. So those hubs, if you go back to the last slide, those two hubs, both at the top and the bottom, those will then be removed once the anastomosis and the flap, you know that it is viable and all of
Right,
that.
they're removed before the patient goes home.
Right. Those are hubs that I'm familiar with from chemo. You know, sometimes hubs are used to administer chemo, and I know other patients are going to be looking at that and wondering when those would come off, so before they go home. Thank you.
So just a little sort of touch on our series. So in the last couple of years, we've done 162 PAP flaps, and the mean age is 48 years, ranging from 32 to 71. Obviously, the patient BMIs are within sort of a lower scale with regards to BMIs, because these are patients who are, more or less slimmer, which is why the PAP flap is chosen as a reconstructive option. You can get a good weight of PAP flaps. I mean, we've gone up to nearly 500 grams with a single PAP flap in terms of weight. But again, that depends on whether or not a patient has had a previous DEP, but they're a slightly larger patient, and this is the choice of autologous reconstruction that they have available. Or if it's someone who's chosen to have their thighs used rather than their abdomen used, but do have good volume in the thighs, which can go up to 500 grams. The mean duration, and we talked about this before, is that it's nearly less than an hour always, which is why, keeping the legs up in the air, we kind of note what time the legs have gone up in the air, but make sure that it's not up there in that position, because surely that can end up in getting a little bit of paresthesia on the posterior aspect of the thigh post-operatively. Most of our reconstructions in our institution are immediate reconstructions, and out of this group of patients, only 20% had delayed reconstruction utilizing a PAP flap. And out of this 20%, some of them were secondary reconstructions where a portion of a DEP has had some fat necrosis and is requiring volume replacement of that area or that quadrant, which requires replacement. So we would put that into the delayed group of patients rather than an immediate group.
I mean, where possible, we like to do an immediate reconstruction, because again, we talk about the footprint of the breast, but the skin envelope, where you can use the mastectomy skin as your skin envelope. If you imagine the breast like a cushion and a cushion cover, obviously the breast tissue is the cushion that's come out, and then we need to replace it with a new cushion, be it either an implant or an autologous tissue. Where you can keep that cushion cover in its entirety, there's no superior reconstruction than that. So when Maleeha mentioned earlier a nipple-sparing mastectomy, and often the incision for that is in the inframammary fold where the bottom of the bra or the underwire of a bra sits, if you imagine the entire skin envelope is maintained, the nipple is maintained, and literally you're keeping the entire cushion cover, what's happening is the cushion's being removed and a new cushion is being placed. Once that heals, I have to say there is no reconstruction that can supersede that, because it's almost unnoticeable what's happened.
So in terms of the distribution of the types of flap, most of our unilateral reconstructions where we have utilized PAP flaps are stacked. So they're two flaps either joined together, similar to what we showed you earlier, or when we are doing a uni or a bilateral single PAP flap, it is because there is enough tissue available to create a breast of similar volume. Rarely we've done bilateral stacked PAPs in association with DIEPs, where we've used the DIEP and a PAP on each side, just because of patient choice and because of them wanting a certain volume or to replace their pre-existing volume. Some of our patients had adjuvant chemotherapy and 8 of them had adjuvant radiotherapy. Why this is important in terms of the PAP flap itself is radiotherapy has a certain effect on the appearance of flaps or the texture of flaps and the texture of your breast after radiotherapy has been carried out. And I think here in our unit, we don't like to give radiotherapy to our S-gaps, for example. So Paul Roblin, who's one of our colleagues here, and has the largest series on S-gaps, is not very keen and won't allow a patient to have radiotherapy to an S-gap because it completely changes the architecture of the fat and there's no point having a reconstruction when it's going to become hard and not have that natural feel for which an autologous reconstruction is being used for. With PAP flaps, we haven't noticed a similar type of change. So we are okay to allow our PAP flaps to be radiated. And we would allow a patient who is definitely going to have radiation, if we know about it, to have a PAP flap reconstruction. This is not the same for when we have a patient who is only suitable for an S-gap, which is a superior gluteal artery perforator flap. We would put an expander or a temporizing sort of reconstruction for that patient, and then an S-gap flap would be carried out. With our DIEPs, we do allow them to be irradiated. And I know many North American centers don't do that. They would do something similar to what we do for the S-gaps. But I think over the years, we've kind of looking at our own data, we haven't seen that there's a huge amount of fat necrosis associated with the effects of radiation in our DIEPs and now with our PAP flaps. So
there is a big difference. I mean, let's say there's a patient who has a DIEP option, a PAP option, an S-gap option, a LAP option. Then the question becomes, why would you choose one over the other? Of course, one is patient choice, but the other is the pliability and the consistency and the texture of the fat in these locations is very different. And the fat in the gluteal region architecturally is quite different. And there's a lot of kind of septi, etc., between the fat cells, which is why it does not react well to radiotherapy. And that's why, in those circumstances, as we've said, we try and, if we know the patient's having radiotherapy, we would do that as a delayed option.
Mm-hmm.
So our mean length of stay for our PAP flap patients is 2.3 days. Majority of our patients will go home on day 2 after having a PAP flap. The ones who stay longer than 3 days then, because there is a reason for them, and that averages it out to a little bit over than 2.3 days. Most of our autologous reconstructions will go home by day 3. And there is the enhanced recovery. We mobilize them day 1, catheters come out day 1. With the PAP flap, we are more keen for them to be walking around than sitting in a chair. Now, with a DIEP flap, you would ask the patient to, on day 1, sit up in a chair because that reduces the tightness around the closure of the abdomen because your hips are flexed and you're kind of, sitting in a more comfortable position for the abdominal closure. With the PAP flap, you can't allow that. So you are more keen for your patients, and patients are as well, more keen to be walking around rather than sitting. And if they do have to sit, they just have to sort of really kind of lean back a little bit and avoid pressure on the area of where the closure is. Now, we mentioned this a little bit earlier in terms of our donor site issues and the learning curve that we had in terms of what sutures we were using. And at one point, we did have a donor site dehiscence rate of 22%, which was really high and quite upsetting. and patients had amazing breast reconstructions. They're really happy up here, but they're so unhappy with the donor site. And our breast Q-proms went down in terms of their satisfaction at 2 weeks and at 1 month, because some of them were still having problems with dressings. And then once we changed the way that we were closing it and did a little bit more sort of monitoring of how we are going to fix this problem, the donor site dehiscence rate went down to 9, and we recently redid this audit, and it's now down to 5%.
Wow.
So, which is acceptable sort of, I can accept that is an acceptable sort of figure to give a patient when it's a tricky area for healing.
Mm-hmm.
But I think it was quite alarming for us to first have this as high as 22% at one point in the beginning.
I think for all those trainees out there, self-audit is very, very important. Don't accept your results. Audit, reflect subjectively, objectively, individually, as a group, as a collective, as a department, because whatever your results are, you can always make them better. And, to say that the donor site, we just have to accept it's 22%, that's unacceptable. You can always improve. You can always evolve your techniques. There's many things that can be, and this is a point of example of that, that we were ourselves were very unhappy, and then we kind of open discussions. What shall we do? We started changing things. And I have to say, the first time we changed it, it wasn't right. We kept changing and changing until we found the formula, which resulted in the right result. And there's a lot of things that had to be changed. It's not just the technique. There's a lot of other kind of rehabilitation factors that had to be considered. But it's just to trainees, don't accept, just keep on pushing yourselves, your unit, your department. You can just get better and better.
That's incredible advice and music to my ears as a patient.
So in terms of our flap failure rate with PAP flaps only is under 2%. I think the failure rate is higher in patients where we are stacking, where we are doing an intraflap anastomosis, or we've had problems where we have done multiple flaps, as in DEPs plus PAPs, where one or the other flap has had a problem, and that brings this figure up. Just a couple of photographs just to show you some results. So this is immediately post-op. We had this earlier on as well. This is a patient who had a right-sided mastectomy and a left-sided reduction, and she had stacked PAPs to her right side and a standard uplift mastopexy reduction. This is immediately post-op, and you can see that both the vessels coming from the top and the vessels coming from the bottom have got the flow coupler wires attached. And this is her sort of couple of months down the line.
So just to go back, this is the side that she's had the breast cancer. You can see that's the blue dye that's been injected for the labeling of the sentinel lymph node. And that's the side where she's had breast reduction. So you can see here, the flaps are a little bit bigger, but we accept that because what we're trying to emulate is the footprint of the breast, the width and the height. And we say to the patients, in order to be able to reconstruct the footprint, we sometimes have to accept that the starting point of the flaps of the reconstruction is a little bit larger, but we can easily address that later with a bit of liposuction and redistribution. As we said before, trying to correct an incorrect footprint is very, very challenging.
Wow.
And as Maleeha said, you can see how these breasts have settled, in the first two to 3 months. The right being the reconstructed side and the left being the symmetrizing reduction. And here, looking at some scars, the aim is, this is preoperatively, the aim is to place the scars as closely as possible in this crease. You can see the scar is here, and you can see the tail end of it. Sometimes you can get an excess of tissue at the ends, like you do on an abdominal DEP flap closure. These are called dog ears. You don't really see dog ears on this side because there's very little in the way of bulk in the tissue here, but sometimes this may need revision, and you can see the scar settling in there. And this is quite a good scar because it's tucked very nicely into the crease. Here we have another patient. Again, you can see she has no tissue for a DEP flap very, very thin lady, and she's going to be having a PAP flap reconstruction. And here she is post-operatively. That's the reconstructed breast on the left side. You can see it's got a very good volume, very good projection, and the footprint matches very closely the breast on the right-hand side. We've covered nipples, but in this patient, actually, it was a skin-sparing mastectomy, and you could see a little bit of skin from both the PAP flaps where the nipple areolar complex used to sit, with a horizontal scar going through them where they've been stitched together. But later on, that skin is used for a nipple reconstruction, and then it's tattooed. So all of that is concealed in the tattooing. And here you can again see the patient's scars posteriorly in this region.
Amazing results, really.
So a kind of just a little summary that PAPs are ideal, obviously, for a slim, thin patient who doesn't have the go-to DIEP flap available, or when the abdomen is not available because a previous DIEP flap has been carried out, or they've had an abdominoplasty. So the blood supply to the DIEP flap has been already hampered, or they have chosen not to have a DIEP flap and would like their donor site scars to be in the thigh lift area. Preoperative CTA is a good way of road mapping where you want to get to your perforators. Lithotomy makes your life so much easier when you're raising the flap. And also, more importantly, when we are closing, just bringing it down and being able to readjust everything by reducing the tension, you're able to move the legs in that position is quite helpful. In our practice, stacked PAPs is the majority because of the fact that we really want to replace that whole footprint that I think Pari's really, talked about it in terms of how important it is to get your basic footprint right in the primary operation. And then you can always enhance it, reduce it, whatever you like. At least you've got that footprint there to work on.
Amazing presentation. I'm going to do it.
Nothing is possible without our team, and we're two of many, many surgeons, many nurses, juniors, etc. And I have to say, I think we both feel very lucky, the environment that we work in. We really, really do enjoy going to work because we have amazing people working with us. And we just want to take this opportunity to thank all our colleagues, all the nursing staff, ancillary staff, juniors who help, deliver the highest standard of care to our patients and make coming to work fun for us.
Yeah, absolutely.
How lovely. How lovely to end on that note, to thank your team members, because it is, it does take a coordinated effort in the theater, which you guys call it. I know in the UK, it's an OR here in the US, but it takes a concerted effort and team effort. So just lovely. Ladies, if you want to stop screen sharing now. I just want to take just a personal note here at the end to thank you. Both of you know I have a background in education, and this presentation, for the patients who don't mind watching intraoperative pictures, but more importantly for, folks who are training residents or our current surgeons, it was amazing. I had very few questions throughout the presentation because you answered everything so beautifully and phenomenally, and it was done in a very, very easy to understand way. So from my personal note, I want to thank you both for spending the time with me today. I'm glad we finally made this happen.
Thank you for inviting us. We're both chatterboxes, and we probably could have spoken for another 2 hours regarding the topic, but we had to rein ourselves in a little
Thank
bit.
you, Terry.
You know what? My podcast, I get to invite who I want to, and I invited you both for a reason. That was my sassy comment today, but really and truly, thank you both. I'm pleased to be able to present these, for patients, because access to care is so important. We know it can be challenging. We will just try, right?
Yeah.
Thank you both for joining me today. I appreciate it.
Thank you, Terry. Thank you very much.
And we will have all the information about how you can find these two amazing microsurgeons who practice over at Guy's and St. Thomas in London in the UK. And again, it's Miss Pari Mohanna and Miss Maleeha Mughal. So thanks for joining me.
Thank you.
Thank you.